right. Good morning, everyone, and welcome from near and far. I'm Ashley Apiaje. I am one of the third-year residents here at UNC in the Department of OBGYN, and we are so excited to have Dr. Anderson with us today. In the interest of respecting everyone's time, I think that we're going to go ahead and get started, and I'm sure there'll be some more people trickling in as we go along. But I will go ahead and introduce Dr. Anderson and then hand the reins over. So Dr. Janine Anderson is an assistant professor in the Department of Health Promotion and Disease Prevention in the College of Nursing at the University of Tennessee Health Science Center, UTHSC in Memphis, Tennessee. Dr. Anderson earned a Master of Public Health degree with an emphasis in health communication and a PhD in communication from the University of Southern California. She then completed postdoctoral research fellowships in the Rollins School of Public Health at Emory University and the College of Medicine at UTHSC. Dr. Anderson's research awards and accolades are many, including grants from the NIH and the National Cancer Institute. Dr. Anderson's research targets the relationship between patient-provider communication practices and clinical and quality of life outcomes among women and adolescents of color. She studies the ways in which patients and medical care providers share power and responsibility to achieve patient health goals in sexual health and chronic disease management. Her professional activities also include developing faculty resources and university-level programming to address diversity, equity, and inclusion goals and objectives. Given all of that, it comes as no surprise to anyone that we're thrilled to have Dr. Anderson here with us today to share her knowledge and thoughts with this community. With that, I would like to welcome Dr. Anderson to take the floor for her idea lecture entitled, Let's Talk About ... Racism, Improving Patient-Provider Communications About Sensitive and Socially Relevant Topics.
Thank you.
Stop sharing my screen.
Okay, perfect. And I'll share mine. Okay, give it away here. Okay. All right, everybody. So once again, thank you guys for that great introduction. Thank you for the honor of being with you all here today. And I am just wanting to hope that today's conversation, that I can say something that piques your interest, that moves you. I hope to discomfort a lot of you. And that discomfort, I hope, is the catalyst for us all moving the needle forward in racial justice, health equity, health justice. So without further ado, I'm going to get started, but I do have a few expectations for you all as my participants. And so, as I mentioned, today's conversation, because race talk is taboo, race talk is difficult, it's unnerving, may be challenging. And so I have some expectations for us to get through this. I'm excited to share some of my research with you all. So I want you all to think of yourselves holistically. I would imagine that many of the folks on today's in today's virtual room have the social identity of healthcare provider, but I want you to bring all of you, your personal and your professional identities to today's conversation. I challenge yourself to remain intellectually and emotionally vulnerable. I am open for the chat. I know Ashley said she's going to monitor it for us. And so engage in authentic, constructive, and appropriate communication during our feedback session at the end, and as well as any dialogue that happens in the chat. And the last is to find some moments of joy in the growth. And so anytime any of you all may have had a scab, or you may have hurt yourself, or you can see new parts growing, it's a little uncomfortable. I want us to find moments of joy, knowing that something that you may have learned or been reacquainted with is going to help you be a better healthcare professional, clinician, student, and overall good person. And so with all that being said, I know it may be uncomfortable for us to think about, but our culture still struggles with the isms. Racism, sexism, genderism, transgenderism, transphobia, ageism, classism. And so despite our best efforts, our work environments, however great they may be, do not function in a vacuum or a utopian bubble. And so the social norms and beliefs that perpetuate power imbalances and marginalized vulnerable groups make their way into those workspaces. And so we as healthcare leaders in our respective organizations have an ethical obligation. I can't say that strongly enough. We have an ethical obligation to create environments where we are able to engage in the difficult but very necessary conversations about the socio-historical constructions of race, racism, oppression. And so I am charging all of you all to be intentional and to be dedicated to not only learning new knowledge and imparting new content knowledge, but engaging in the growth journey that builds our critical consciousness capacity. And so those moments of growth, that discomfort, that inquietude is indicative of the type of growth necessary for us to really engage in the kind of equitable, patient-centered communication necessary to improve health outcomes, to regather, have people join the medical establishment again, and to, reduce health disparities. And so here's a number, 13.8. And 13.8% represents the number of Black patients who have a primary care provider or their normal source of care provider who identifies as the same race or ethnicity as them, so 13.8%. Now this is compared to 94.4% of white patients who have a race concordant provider and about 45% of Latino or Latinx patients. Now, what this means is that the likelihood is that Black patients are going to have a race discordant provider. And so I'm going to talk later in this session on what that means and how that impacts healthcare. But what is interesting is that current literature doesn't necessarily agree that a race discordant patient-provider relationship necessarily means poor communication. In fact, some patients don't have any preference for the race or gender of their provider, but instead prefer things like emotional support or clear communication or equitable talk time. And so the reason I mentioned that the literature is not clear about if it's preferable for race concordant relationships is that it means that all of us, particularly white healthcare providers, can move the needle forward in having these difficult conversations, even if your patient doesn't look like you. But it is important that we are mindful of the external factors in the communication environment that can make that kind of communication difficult, if not tragic. And so I'd like to review some key concepts related to this talk so that we can all be focusing and working on the same common definition. Oftentimes miscommunication happens when we're working from a different knowledge bank. And so after presenting some concepts, I think that are key to helping us understand why patient-provider communication about racially charged and sensitive issues can oftentimes go awry in the clinic setting, I'm going to use some communication theory to help us better manage the communication environment and then provide some suggestions for how we may improve. And so the first one is the definition of race. And so someone has said that race is a pigment of our imagination. So race is a social construct, and it was developed for the purpose of creating and maintaining privilege, power, and systems of oppression. Now, to acknowledge that race is an arbitrary historical intervention does not negate the fact that race is consistently dispatched in sometimes insidious ways and always impacts the lived realities of individuals. And so our world is ordered and structured on the basis of skin color. And that oppressive ordering is racism. It is pervasive in our US socialization. And I would offer that it is oftentimes almost virtually impossible to live in our US contemporary society and not be exposed to some aspect of the personal, cultural, or institutional manifestations of racism in our society. Privilege. Now, all of us in this virtual room have some privilege, some more than others. Privilege is the unearned access to resources or social power that grants advantages or immunities to some individuals above and beyond the common advantage afforded to others. And so privilege is oftentimes invisible to those of us who have it. And if we are not careful, privilege can be disguised as meritocracy. So we understand that in our cultural context, this idea of pulling yourself up by your bootstraps or using your own internal fortitude often negates the real ways in which privilege works behind the scenes. What is interesting about privilege is that there are hierarchies to privilege, such that patients and health providers may find that some social identities afford them some level of privilege, but it may be outweighed by others. So for instance, you may find that healthcare providers who are part of marginalized social groups, but I'm specifically talking about Black, Indigenous, or people of color, may find some kind of privilege within their work environments, and that privilege is then snatched away once the white coat is removed. Or they may find that even their white patients may have greater privilege in terms of being heard or believed, even above them as healthcare providers. Oppression. So the combination of prejudice and institutional power, which creates systems that discriminate, is oppression. Okay? And so oppression creates these target groups and the dominant groups. And so the agents of oppression are privileged by birth or acquisition. And so what we know about oppression is that it is a system. It functions in a way that removes and denies access to folks in the target groups, oftentimes, as I mentioned, Black, Indigenous, and people of color. It removes those access to basic necessities, healthcare, education, employment, and housing, and diverts those resources to the dominant group. And this is a systemic social contract. And so I say that oppression is unfortunately our country's hidden secret. There are the ways in which racism or race and privilege are dispatched to compound resources in one group, the dominant group, away from others. We're seeing it not only the ways in which healthcare resources are doled out, we're definitely seeing it in our economic system, we're seeing it with educational injustice. And so in virtually all domains of our society, we see the ways in which the isms, those systems of oppression, remove advantage from one group and place the advantage above what is common for all to another. And so many of you all may have heard of this concept of implicit bias. And so this is also another concept I wanted to address for our conversation today, because I think it is, I'd like to believe, I'm sure you all would like to believe, that healthcare providers have taken an oath of care. Many would say that, yes, I understand that these isms, these systems of oppression are functioning in society. But when I put my white coat on, Dr. Anderson, when I put that stethoscope around my neck, when I ascribe to my social identity as healthcare provider, I try to leave all that at the door. My job is to heal and to help the men, women, and children in front of me who are ill or infirm. And I would say that's lofty, and that's great. But what we know is that implicit bias is unconscious. And so implicit bias is a term that speaks to a variety variety of evaluative judgments, that we make. And so in psychology, the theories suggest that individuals hold two distinct ideas about an object. And so there's the explicit attitude that we verbally articulate, and the implicit attitude, which we are either unwilling or unable to report. And so what is important about implicit bias is it is an unconscious cognition, We activate them very quickly. This is why oftentimes implicit bias and stereotypes go hand in hand. It is an unconscious, quickly activated heuristic by which we make decisions. And so because it is quickly activated and oftentimes unconscious, if not always unconscious, it is really resistant to our conscious attempts at trying to manage them, so to speak. And so the inconvenient truth is that even individuals who espouse egalitarian ideals, even individuals who report few explicit biases, still maintain implicit biases that would have them to discriminate. So the real truth is good people, good physicians, good nurses, good healthcare providers, good people discriminate. And so speaking of implicit bias, I'm not sure if you all have heard of this term, but I think it's germane to this conversation, and that is aversive racism. And so aversive racism is low pro-white explicit attitudes. So low pro-white explicit attitudes would mean a person who identifies as white having low reports or measures of a preference for white individuals above others. So a low pro-white explicit bias, but a high pro-white implicit bias. So this individual wouldn't necessarily report a preference for white individuals above those of color, but unconsciously does have that preference. And so I want to read you a definition of aversive racism that was written by DeVito and his colleagues. He's been a prolific writer, and he says this about aversive racism. Aversive racism is a fundamental discrepancy between the egalitarian attitudes which an individual consciously endorses and their implicit negative racial attitudes which they do not recognize. Because of their explicit egalitarian orientation, the feeling that aversive racists experience toward other groups is not of hatred or open contempt, which motivate direct harm, but rather anxiety and discomfort, which leads to avoidance. Moreover, the negative feelings of implicit attitudes are they threaten a individual's perceived non-prejudiced image. This contemporary form of racism is termed aversive because these well-intentioned individuals would find aversive any suggestion that they are racially biased. And so the way we know that aversive racism happens is that there are just differential value judgments placed on individuals. And so I think the best way to describe aversive racism might be through some questions that are oftentimes asked in the patient-provider relationship. Is my time well spent with this patient? Will I receive the positive feedback and affirmation of a job well done from this patient? Or will this once again be an unpleasant, unfulfilling experience of not connecting and of suspicions of my motives? So we see once again this very clear demarcation of in-group and out-group. Can this unsophisticated patient be a capable partner with me in the ongoing therapeutic alliance? Does this patient deserve my time and scarce resources? And lastly, is his, her, their life worth prolonging or enriching? And so these are some questions that hint at aversive racism. They hint at this differential assessment or valuation of one group's life, the dominant group, versus another. And so in these, I would imagine, because I've heard some of these questions uttered walking the halls of my institution, and not necessarily any nurse or medical provider asked these questions directly. These may be the questions that linger in someone's head when trying to provide care. You all have busy schedules. Your time in the clinic visit is far too short. There's a scarcity of resources. And so aversive racism creeps up when we start to ask questions about who deserves the best access to care, who deserves the best access to our communication and our expertise. This is where the insidious nature of implicit bias rears its head. And so the last bit that I want to share with you guys in terms of key concepts is this idea about epistemic injustice. And so the concept of epistemic injustice refers to injustice that is done or is a wrong done to someone specifically in their capacity as a knower, okay? Specifically in their capacity as a knower. Now, there are two types of epistemic injustice, and this is unequal access to the position as epistemic authority, or the authority over knowledge and knowing, and then unequal epistemic status given to different types of sources of knowledge. And so, for instance, what we know is that for the first type, for a very long time, for generations, women were not medical faculty. They were not thought to have the type of skills or mental wherewithal to impart knowledge to the future generations of male doctors. And the second part speaks to the unequal status in types of resources, types of sources of information. So we oftentimes disregard indigenous or non-Western knowledge. We definitely have thought of oral traditions as superstitious or irrational. We oftentimes disregard qualitative data versus over quantitative data. We devalue the personal testimonials over what we call scholarly empirical data. So this is epistemic injustice. And in the patient-provider relationship, epistemic injustice gives way to epistemic microaggressions. And what that means is that oftentimes a medical care provider or a clinician who is afforded epistemic privilege by virtue of his or her medical training position as a medical authority can remove the authority or the autonomy or the empowerment of a patient to tell his or her story by not listening, by devaluing the ways in which an individual tells his or her story, and marginalizing them as unreliable, as ill, as having some kind of moral defect simply because of their status as an ill patient. And so I can't see everybody, and we're not, in a physical space where I could sense the vibes in the room. That's to my disadvantage. But I could imagine that if you have been following, as I have broken down ideas about race and racism and aversive racism, that there may be a time where we need to just collectively breathe. And I really mean this. If at anything I said and I know I'm moving through these concepts quickly for the interest of time, but discussions of race and racism invariably make people uncomfortable. The discussion of aversive racism may have pricked someone who was discouraged or angry about the duplicity of explicit biases or their explicit goals of trying to provide the best patient care, and the insidious nature of the implicit biases that we all have about folks who are different from us, and how that may unknowingly or unwittingly or unconsciously mean that many of you may have discriminated or provided suboptimal care to patients simply by virtue of unconscious cognitions about difference. And so I'm not going to disregard in this moment that this is why race talk is difficult and why there is so much resistance to it. Because race talk is taboo, it violates politeness norms, it makes people uncomfortable. Some people see it as inappropriate and even question why it comes or why it would be appropriate in the medical setting. And so in this moment, while we're taking a collective breath, I want any of you all who have the inkling to say, you know what, this has been fun, Dr. Anderson, but I think I'm going to do something else, to push through that discomfort, those inquietudes that come with perhaps realizing that you have engaged in biased healthcare, that you yourself have engaged in aversive racist behaviors, that you yourself have perhaps been epistemically arrogant and denied patients the full knowledge of their treatment options or denied them the full opportunity to voice what they needed to share about their health condition happens. And so now I'm hoping to provide a little bit about what communication theory says about the communication environment, and then some suggestions for how we're going to move forward. But the reason why I wanted us to take this little collective breath is for any of you all who may be taking notes, this is the time for you to write down what you're feeling in your body. When I do these kind of trainings in implicit bias at my institution, I ask individuals to have 2 notebooks, writing down what you would normally do in the clinic environment, in the clinic interview, and also writing down what's running through your head, what you're feeling in your body. Are your shoulders tensing? Is your forehead wrinkling up? These are the embodiment of the anxiety and the distance that we know comes with bias. And so this is an opportunity where I'm giving all of you all to think about what I've mentioned today and the ways in which racism, whether you're a person of color or not, is feeling in your body in this moment. And we can talk about it during the Q&A. And so, as Ashley mentioned, I'm a communication scholar. And so I have found it helpful to think about the ways in which communication theory can help us understand the noise in the communication environment. Because part of my talk today is about improving patient-provider communication. I know that the inkling is to say, great, she's going to tell me more about how I can be a better communicator, about how I can better ask questions in the clinic environment. She's going to tell me how I can maximize those 7 minutes so I can fit everything in, because the communication breakdown must be happening because of something I'm saying or something that my patient is not saying. I'm a trained medical professional. If my patient would only give me the information I need, I can figure out the diagnosis. And so I'm offering communication theory to help us understand that oftentimes the communication breakdown between a patient and a provider has less to do with miscommunication or poor vocal utterances and more the noise in the communication environment. And that noise I alluded to, epistemic injustice and aversive racism. So I know I may have a few comm scholars on the call. And so I'm going to run through these quickly because communication models have been helpful for me to understand what may be happening here. And so Feldman Stewart is a tried and true communication model. And what I want you all to get, because I'm going to show you three models or three conceptual frameworks, is that both the patient and the provider come to the communication interaction with their own needs, skills, beliefs, values, emotions, that is influenced by external factors. This is culture, this is religion, this is social identity, politics, everyday interactions. Both the patient and the provider come to the communication environment with those, trying to make goals, but that entire interaction is filtered by the environment. And you will see, once again, Richard Street's ecological model, very similar. The patient and the provider come to the interaction with their own predisposed influences, their own personalities and histories, but it is influenced by what is around. That is the context that the communication interaction is happening in. And lastly, Giles's communication accommodation theory, I think, is probably most germane for this conversation about patient-provider communication, because it speaks to the fact that both the patient and the provider, here we'll just call them individual A and B, are coming to the communication environment with their own intergroup history. Okay, so Giles's communication theory speaks to the fact that our social identity, our in-group social identity influences our communication just as much as our own individual personalities. So when I come to you all today, in part, I'm coming to you with my in-group identity as an assistant professor and a scholar. I'm not necessarily coming to you as homegirl Jay. And when I go and meet with my healthcare provider, I have to negotiate which version of myself am I going to bring to the communication environment. To be fair, oftentimes I introduce myself as Dr. Anderson in the medical environment simply because I know that curries favor for me. That shows that there is some similarity. I'm an in-group member. I very rarely just say I'm Janine anymore. And so Giles's communication and accommodation theory tells us that there are power imbalances that happen with those social identities. Remember, we talked about epistemic injustice and how there is privilege based on people's role as a medical provider versus a patient. And so when they come to the communication environment here, accommodation theory says that folks who are in privileged positions are less likely to accommodate the needs of individuals who are in lesser positions. So what this means is that providers are less likely to use similar language. They're more likely to use medical jargon. They're more likely to speak in complex sentences, more likely to use data-driven, evidence-based language versus narrative storytelling that their patients use. And so that divergence in the types of language that's happening is what does two things. It creates miscommunication, but it also reifies difference. It reifies the power imbalance. It reifies that your patient and your provider are often very different. And so this is where race concordance can help bridge those gaps. But what I wanted to show you guys a bit about theory is not so much that I'm trying to get any of you all to go back to school. Excuse me, I'm looking aside for my notes, pardon me. But what I want you guys to gather is three things from showing you all communication theories before I move to the suggestions. And that's first is that patients and providers bring their individual personalities, their in-group identities, and their collective memories to each communication interaction. So a clinic visit about pain or anxiety or allergies is not just a visit about pain or anxiety or allergies. Each provider and patient is bringing their collective knowledge, their collective memory of what it is to talk to a person in that oftentimes out group about any issue. There is, number two, a shared goals. There are shared goals between patients and providers. And I'm still idealistic enough to believe that that shared goal is patient health. What gets in the way, ladies and gentlemen, are all of those external factors. I alluded to several of them today. And so this is why a discussion of race and racism in the medical establishment, a discussion of race and racism in your clinic room, in your visit with your patients is critical. I offer that shared decision-making about health goals is futile unless the communication environment is open to the ways in which race and racism impacts people's health. And that communication environment is consistently maintained. And the last thing is it isn't all about you. I know that's hard sometimes for medical providers to hear, but it's not all about you. That part of what we hopefully saw in those models is that good communication is not one directional. Good communication is not you talking and listening only with the intent to fix or prescribe. Good optimal patient-provider communication is a two-way, dynamic, shared process of give and take, of vulnerability, of shared disclosure. What's really interesting is that many of the women that I work with who are in their cancer survivorship stage say, I know that my provider is competent, but he or she is not in my body. He or she is not living with this cancer. And so I'm the expert of this body. And that empowerment is what I'm hoping that the suggestions I give you all in the time remaining will prick your attention, because patients do want to engage in an equitable, shared decision-making experience with you all. And for your Black and Indigenous and patients of color, that experience living in their body is oftentimes, if not all the time, influenced by the insidious nature of an oppressive system in virtually all aspects of their daily life. And so a conversation with you in the clinic visit invariably is influenced by that reality. And so, since I'm running out of time, the fun stuff, suggestions. No one is going to buy me any cupcakes for this conversation, so no worries. So the first thing is I'd like to offer that the improving patient-provider communication about sensitive and racially charged issues is going to take a multi-pronged, multifactorial approach. But the first thing I want to say is that I have no doubt, and I hope you don't have any doubt either, about the importance of broaching race and racism in the medical context. And so in a very real way, discussions of race and racism communicate its value and appropriateness in the clinic encounter. And it supports patients who may experience microaggressions or discrimination in their homes and their workplaces and their schools. And particularly for adolescents and young adults, having a healthcare provider who can support their articulations of feelings of discrimination is important for them to process what they're experiencing. We have all in this past year, and for many of us, I know this past year was kind of a watershed moment when all of us unfortunately collectively saw the murder of George Floyd, and we know about the murder of Breonna Taylor and Ahmaud Arbery. But for those of us who are men and women of color, particularly I'm a Black woman, I've been struggling since Michael Brown in Ferguson and Sandra Bland in Dallas. And so the ways in which racism had been doled out publicly in the criminal justice system, or injustice, very much impacted my mental health. And so I could only imagine, having been a teenager during this time, trying to figure out my way in the world. This is where healthcare providers are, I would offer, charged with engaging in these kind of conversations, particularly if you are providing care to adolescents and young adults. Having race be a taboo subject rips away, the opportunity for you to develop an independent, close relationship with your adolescent and young adult patients. And it sets the tone that this topic is not appropriate for the medical environment, and that belief persists, what we know, along the life course, such that I would imagine that there are adult patients who would wonder why this is an appropriate topic for the clinic environment. And so the three-pronged approach I have here in the time remaining is, first, I'm advocating for cultural and epistemic humility. And I just kind of put the little tagline, listen, believe, and acknowledge. I know it probably hopefully goes without saying, but really listen to your patients. And part of listening in the medical, in the clinic encounter, is about asking the right questions and listening just for the piece that would help you all as clinicians come to the right diagnosis and treatment. I would offer that optimal patient-provider communication affords both the patient and the provider the opportunity to listen to one another without the only intent being medicalized treatment. Oftentimes, listening affords the patient an opportunity to disclose and to build a kind of trusting relationship that we know is key to patient satisfaction, medication adherence, and good health outcomes. And so this is why believing and acknowledging patients whenever they share their testimonies about their understanding of health and illness and the reasons why those things are happening is key for the type of communication necessary for clinicians to do their jobs well. And lastly, the bit about acknowledging and vulnerability, I do want to add, because I've had the pleasure of working with youth in the sexual health space. And one thing they always say is, my provider never shares. Being part of the medical encounter sets me up for so much blame, shame, and judgment. I'm blamed for poor eating. I'm shamed for my risk behaviors. I'm judged for my sexual and gender minority status. I am required to disclose so much of the vulnerability that is who I am in this stage of my life. And my provider just listens and just nods his or her head and never has to share or shoulder any of that vulnerability, never has to share or shoulder any of that angst about disclosing who they are. Now, this comment may be kind of contrary to what is usually taught in medical education, but I would say that when it comes to racially insensitive issues, it is important for providers to share some of that emotional vulnerability, which would require some acknowledgement and disclosure. And lastly, students shouldn't be left to do this alone. I've really been thinking about this last part because I was talking to a colleague. Her name is Dr. Brooke Cunningham out of the University of Minnesota, and she's a general internist and a sociologist. And she gave some suggestions, and a lot of them had to do with how Healthcare providers need to be mindful about the embodiment of anxiety about racism. They need to manage negative outcome expectations, manage the fear that conversations about race and racism in the clinic environment will go to the left and end up in yelling and hostility. And I thought about medical students may not be ready to engage in that kind of reflexive and positional interrogation of themselves. And so I'm offering that a critical and an anti-racist pedagogy in medical education may hopefully lead to the type of inclusive learning environment necessary so students have the space to do this. This is vulnerable work. This should not be, please let me say this before my time ends, this should not be a one-off, one-time conversation. This should not be a one semester, 1 hour optional elective. If medical education is really going to help medical students, trainees, young physicians engage in the kind of difficult communication that is necessary for improved patient outcomes and reduction of race-based health disparities. Medical education must create the space with targeted pedagogies that allows students to examine their biases, create opportunities for intergroup conversations, create opportunities for practice, role play with standardized patients and avatars and digital tools. And so as much as I hopefully have communicated an excitement and an eagerness about engaging in these kind of topics with your patients, it is better to do nothing and not engage than to send students out, young people out, young medical professionals out without the appropriate, consistent scaffolding and training necessary. Because who really pays the price are your most vulnerable patients. And lastly, the trainings and interventions. So there's some work being done currently by as a group, Cantor and others who are actually just published a small scale study. I can send the resources to those who are interested about an intervention that's designed to train patients about how to deal with racially charged conversations in the clinic environment. And they have found that what was effective was helping providers through trainings develop emotional rapport and responsiveness. So you can see that they have found that it's less about encouraging patients or providers to improve their quote unquote communication skills and more about developing the kind of emotional rapport and empathy necessary to elicit honest conversations with patients about what they are struggling with. And so with that being said, I do have one more slide about implicit bias interventions, but I'm much more interested in opening up the floor for questions. I know this hour went by fast, but I do want to thank everyone for your attention. And now, Ashley, I'm willing to open up the floor for questions.
All right, thank you so much for that amazing talk. I think that you touched on a lot of things that are relevant to us on a daily basis in our clinical work. We're still waiting for some more questions to trickle in through the chat. I have one, which is that I would love for you to shed some light in terms of your work from patient experiences about this one specific topic, which is patients with what some would describe as limited literacy, health literacy, and the discrimination in those clinic visits. I think that many of us work with populations with patients who would be described as such. And in terms of time, I think that many people would say that those patients actually have more time spent with them in their visits than other patients, but I don't necessarily know that we can say that the outcome of those visits is the same. And so I'm curious, in some of your work with patients, from their perspective, what some of the thoughts are about that.
Right. And it's interesting. Thank you so much for the question, because a lot of my most recent work has been in the oncology space. And so what I have found is that regardless of a patient's socioeconomic status or even educational status, many patients would even self-report to have low health literacy about the complex nature of oncology, of a breast or a gynecologic cancer. So it's been really interesting to see the ways that how we term low health literacy. And I have found that this is where the topics that I talked about of epistemic injustice or epistemic privilege really come to bear, because the women that I work with are all Black women. And they talk about feeling as if they're not being heard. I recently published a paper where there were some race-based differences in actual informational support. Black women were not given the same information about their diagnosis. They were not given lab work with the same frequency. They were, in a more paternalistic way, told what their diagnosis was going to be, what the treatment would be, and scheduled. And so I literally had a woman who said, I was told my diagnosis, and then I had breast removal, hysterectomy, all within back to back to back. And so I asked, well, was that your plan? And she said, I don't even think I was asked what my plan was. And this was a college educated master's level a woman. So she could have been told. And so if I'm hearing the question correctly, I think the ways that health literacy or our perceptions of health literacy can marginalize patients is worth us thinking about. I understand that there is a responsibility that healthcare providers have to not burden their patients with information that they may not be able to digest. I would offer, hope you all ask me back, but I would offer that may be the source of some epistemic arrogance. That may be the idea that a patient cannot understand, that a patient cannot understand what's happening. I would offer that that's because we're oftentimes privileging the reports, the scholarly articles, the data-driven number crunching reports, as opposed to what I've been doing in my work is using peers as peer scaffolders who tell their stories. And so I think because we don't privilege all types of information sources, narratives, testimonials, pictorials, that's why we are seeing what we call low health literacy. Perhaps what we really are seeing is proof of epistemic arrogance.
I think that you touched on a lot of great points there. I think especially in terms of that, looking at some of the frameworks that you showed and that back and forth between patients and how we're interpreting what we're hearing, I think is something that's really important to think about. I'm going to get to another question that's in the chat from Monica Salib, who is from GW. Thank you so much for this wonderful talk, Dr. Anderson. As a third-year medical student involved in medical education, I 100% agree with you that with what you've said about diversity and inclusion conversations in our curriculum. GW in DC has worked a lot on this, and I feel like it's been a big portion of my medical school experience thus far. My question for you is, as a student who will start to look at OBGYN residency programs this year, interested in keeping and growing the space for diversity and inclusion training that GW created for me, what advice would you have on identifying residency programs that will be able to foster this sort of learning environment, especially now that most things are virtual and may continue to be virtual?
That is a great question. And I just it's interesting that I got that question. So I just did an implicit bias mitigation training for the pediatric surgery fellow residents at my institution. And so what I said to them, and hopefully I'm answering the question about what you should look for, because things are virtual, and I know that's a disadvantage. We're not necessarily getting to spend the 3 or 4 days where you have the cocktail parties and you kind of get the vibe for people. I would ask very direct questions. Ask what you want to know, because a institution that has at least thought about issues, let me just not even say thought about in a very intentional way, their challenges, their resources, their plan moving forward, will be able to articulate that to you even if they haven't done anything as of yet, if that makes sense. And so I think right now what's happening is, I'll be really honest. I did a presentation a couple of months ago for nurse practitioner faculties, and many were saying, whether we like it or not, George Floyd's death really awakened racism to me. I tried to save my scrunchy face, but if that's where people are, then that's where people are. And so what it means is that in a very real way, some institutions have only had a year to really think about the ways in which they're going to revamp programs to not give diversity and inclusion and equity lip service. And so as you are looking for programs, I would ask the hard-hitting, tough questions that make you feel like this next place is going to foster the kind of learning environment that you need. A place that is unable to answer the question, seems unwilling, seems discomforted, or even annoyed, is definitely a clue that that may not be the institution. And I would also offer that you may ask questions about the overall culture and the support systems that scholars have, residents have, for engaging in this kind of work. I don't want to put, and I always hate to put extra work on young people, but in a very real way, a lot of this work that we're doing, we're moving into this space together. I'm seeing a lot of Black women. We are taking reins in this area. And so I would ask about what support mechanisms are tangibly available for you, if that's called mentorship, if it's access to resources, if it is a speaker engagement series like what we're engaged in now. Forgive me if the answer to your question is not as finesse as you would like. I'm not a medical provider, but I think what I would be looking for is an institution that was able to answer my questions, show a vision, and provide a very detailed plan for how I could be supported. And if I didn't answer your question well, my email is down below. Let me get another chance. I'll get some professionals on to answer. And actually, if I may say that, I know we're running out of time, but I know there are a lot of people who may be on the call or on the virtual room. I literally put my cell phone number and my email address for a reason. I hope this is not, I know this has been a one-way kind of communication here, but I'm a junior scholar. I am doing this work and I am looking to connect with folks. And so please, 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 if I said something today that interests you, angered you, whatever the range of emotion is, if you're interested in learning more about who I am, I'm interested in learning about who you are. I'll stay on as long as people want me to, but please, please, please reach out to me via phone or email.
Thank you so much. Monica, I think it was actually really great to hear your response on that, Dr. Anderson, as someone who's been working in between a lot of institutions. Obviously, many of the residents here at UNC are also very open and willing to have those conversations with applicants. And so please feel free to reach out to us at our Rabia Lectures email address, or you can find a lot of our email addresses on our website if you have more questions about that in particular. We are unfortunately out of time. And so I do want to thank Dr. Anderson again for spending this time with us and sharing your very thought-provoking talk. It was a pleasure to have you and to get to know you better today.
Thank you guys. I once again appreciate you, and I thank you for allowing me the opportunity to share. And seriously, I didn't put my social media handles on there, but email me, let's connect, and everybody enjoy the rest of your day. Thank you, Ashley, for being a great moderator today.
Thanks to everyone for attending.
Bye.